When you need to build up your team to handle the growing chaos at work, use Indeed Sponsored Jobs. It gives your job post the boost it needs to be seen and helps reach people with the right skills, certifications, and more. Spend less time searching and more time actually interviewing candidates who check all your boxes. Listeners of this show will get a $75 sponsored job credit at Indeed.com/podcast. That's Indeed.com/podcast. Terms and conditions apply. Need a hiring hero? This is a job for Indeed Sponsored Jobs.
This episode is brought to you by Accenture. When your advertising operations fall out of sync, everything else follows. Spotify and Accenture are working together to reinvent the rhythm of ad sales, using automation, analytics, and smarter workflows to simplify campaign delivery and access better data across the business. The result? Less time spent on operations, more time connecting brands with the moments and fandoms that matter most. Learn more at accenture.com/Spotify.
This is Addiction Medicine Journal Club. I'm Dr. Sonya Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This podcast offers Category 1 CME credit through MyCares and Michigan State University. The links are in the show notes, and for our dedicated listeners, you may have noticed that a few months ago, we got kind of behind on uploading our CME modules, but we are now up to date on our CME modules. So if you were looking for more CME, you can see CME for all of our back episodes at the link in the show notes. This week, we are going to be discussing phenobarbital for alcohol withdrawal, and John's going to take us through that article. But before we start, John, how are you doing?
Living the dream, enjoying a nice Wednesday night after clinic in this hot and humid South Central PA weather.
Yes, the heat dome has dissipated, but it is still hot.
Yeah, for like the whole month of June, it felt like it was like not humid and nice here. I'm like, oh, I live in like San Diego. And then it came.
Oh my gosh. Well, hey, John, is there anything you want to tell our listeners from Addiction Medicine News this week?
Yeah, I think this is a really exciting article. And actually, this just came out from just like 5 days or 6 days ago from July 2nd from The Hill. It's an article about DEA moving to ban opioid-like kratom compound 7-OH. So I think anyone that's kind of been listening to the podcast for the past year has first learned about kratom, and now I think has also heard us rant about it on several occasions. But I think this is really kind of positive. So the DEA just announced that they're going to temporarily classify 7-hydroxymetragenine, which is 7-OH, and related synthetic compounds as Scheduled 1 drugs. So, currently they're unscheduled. You buy them at your local gas station or florist office, and you can just get them. But now they're going to put them in the same category as like heroin, LSD. The proposed changes actually target specifically some of the synthetic higher concentration formulations of the 7-OH. So not kind of a naturally occurring compound, kind of these synthetic groups that are being sold as gummies, tablets, shots, or some of them come like those little energy drink containers. And the ban also includes 3 other synthetic related compounds. It's MP, MGM-15, and MGM-16. So they're actually not naturally occurring compounds. They're kind of synthetic analogs that are added in, and they kind of behave opioid-like. So very similar to kind of like a over-the-counter opioid in some regards. The DEA cited the high abuse potential, tolerance, dependence, addiction risk, unpredictable effects. I thought it was really interesting because, this came from the DEA and from HHS, and is interesting. This kind of broke rank a little bit with the base of that group currently politically. So a lot of kind of activism groups and kind of like alternative health influencers have really pushed these products. So they actually said it put like RFK Jr. in kind of quite the pickle to make this decision. It was not popular at home. It does not, of note, ban any of the traditional botanical kratom products. So if you want to buy and get your natural kratom, just not the chemically modified one, I guess that's still good for the time being. I don't know where you would get that. It's certainly not a gas station. Although, Sonya, you would know. Where would you get it?
Regular kratom, or it's the metragenine?
Yeah, regular kratom.
Well, John, in my small town of Gettysburg, Pennsylvania, 8,600 people, there are 8 vape stores that sell kratom. So 1 for every 1,000 citizens, there's a kratom store.
Man.
So everywhere is the answer.
They also talk about that, not unsurprising, just like many of our other products that are kind of marketed towards children, that it looks like candy, comes in candy flavored products. It looks kind of bright, colorful, kind of attracts not your typical adult audience. So they definitely kind of called them out on that. This is a temporary scheduling, so it's only going to last for 2 years with possible extension. I can't imagine this isn't going to be extended or become permanent.
Yeah. No, I think it's a great move. I mean, I think a lot of people do use kratom recreationally. They enjoy it. They're mildly addicted, but not, not life-changing or life-destroyingly addicted. So fine, they're adults. People can do things that aren't the best for their health. But these concentrated products, these 7-OH, I don't think they really have a lot of legitimate use. And it seems like people just get really, really addicted to them really quickly. And then they have to seek out medical help. So yeah, I think this is a good move. I'm glad the DEA is stepping in here.
Yeah, it's awesome. How about you, Sonya? What do you have for us?
So I read one in a series of articles in Stat News. I don't know if you subscribe to Stat News or not, but they're doing a series called Alcohol, the Deadliest Drug. And a recent article talks about how the MAHA movement, since we're talking about RFK Jr. right now, how the MAHA movement is not only ignoring alcohol in its efforts to get to the root cause of disease, but they're actively suppressing research that shows the danger of alcohol use and dismissing the dangers of alcohol. Alcohol kills more Americans than opioids, infectious disease, pesticides, and red dye combined. And yet Kennedy, in his efforts to, make America healthy and get rid of root causes of disease, has just been ignoring alcohol. Their recommendations, official recommendations are, quote, use common sense when you're drinking and, quote, don't have it for breakfast. But neither of these are recommendations of a group that takes this issue seriously. It's just another indication that no matter what RFK says, he's not actually interested in improving health of Americans. He just wants to push his own kind of bizarro agenda, informed by whatever pivotal experiences he had when he was young and impressionable man in the 70s. I think that's why he's into psychedelics and cannabis. And, he wants to get rid of dyes and pesticides, but he doesn't like, infectious disease or medications for mental health disorders or medications for addiction. He just sort of, I think he imprinted on a bunch of stuff in the 70s when he was like in his 20s and we're all young and impressionable, and he hasn't really developed beyond that or like adapted to any sort of new research. But anyway, congratulations to Stat for this excellent series. I really recommend people read it. Or, it's not a complicated set of articles. They're really great. So with that said, John, are you ready to talk about our article, speaking of the dangers of alcohol?
Yeah. Although I'm kind of glad that we can all agree that we should avoid alcohol for breakfast. It's probably a good start. It's sort of like your sugary beverages.
Oh my God. And no Fruit Loops and no alcohol for breakfast.
I have a couple boxes of the good Fruit Loops. I haven't opened like before the pre-dye ban. I think one day they're going to be worth something.
It's your retirement there.
It's like when the people have those unopened bottles of Coke and stuff. So I was really kind of interested in this article mostly because it kind of hits close to home. A couple of years ago, just background, like the hospital that I work at, we did kind of revamp our alcohol withdrawal order set. And it's really interesting because like medicine had really kind of favored benzodiazepine-based protocols for the most part. ICU really liked their Precedex. But, the ED and toxicologists were really kind of pushing the addition of phenobarbital to our hospital formulary or our alcohol withdrawal pathway. And I'll be honest with you, kind of at the time, it was not kind of something in the literature that I had been reading too much about. Although subsequently, since that changeover about a year ago, certainly it seems to be becoming increasingly utilized. And so this article is called Hospital-Wide Implementation for Clinical Outcomes and Safety of Phenobarbital for Alcohol Withdrawal. This was from JAMA Network Open from just last August. I thought it was really interesting for me to kind of fresh up on the topic and understand a little bit better about kind of when this should be used, why we're favoring this, and kind of any pitfalls or concerns. I guess my first question for you, Sonya, is have you ever used phenobarbital for alcohol withdrawal?
I have not. No, I do almost entirely outpatient, so never gotten to use this protocol.
Okay. Well, you rallied up during COVID. You were inpatient for a period of time. Give yourself credit.
I did do inpatient, and we did not use phenobarbital for people who were suffering from alcohol withdrawal at that time in that hospital.
Yeah. Yeah, I think it's a really interesting question because I feel like it comes up a lot where like people are admitted for like alcohol withdrawal and it's tough. It's day 6 and their CWAS score is so high and they're on high doses of benzodiazepine. So it's interesting to see another option. So kind of background here, I think everyone knows that benzodiazepines remain the standard of care for alcohol withdrawal syndrome. But it's associated with delirium, dependence, adverse drug reactions, certainly kind of over sedation or overdosing of benzodiazepines has kind of occurred classically in many settings. Phenobarbital use is actually quite increasing. When you look at in U.S. hospitals, it went from 6.1% of kind of U.S. alcohol withdrawals up to almost 18.4%. That was from 2016 to 2020. And this actually kind of led to it being a recommendation from ASAM as a first-line option for alcohol withdrawal, as long as the caveat being that an experienced clinician is kind of involved with the management of this. Did you know his first line?
No, and I was going to say, if ASAM recommended as first line, it's just a sign of how slowly the medical community moves that only 18% of hospitals use it, even though it's
Yeah.
considered first line.
Yeah, so potential advantages of phenobarbital. So, as anyone that kind of knows the physiology for alcohol withdrawal involves a mismatch, right? It's a mismatch of GABA, which is an inhibitory neurotransmitter, and glutamate, which is excitatory. And so currently benzodiazepines really kind of work mostly by kind of accentuating just the GABA component. But the thought is that phenobarbital actually kind of has a dual mechanism of action, right? So it has both GABA agonism, so it increases kind of the sedatory properties of alcohol that's being missed with withdrawal, but also it inhibits glutamate. So it has a dual role. And that's kind of theoretically why it kind of works much better. Well, it does work much better, but that's the theory behind it as well. It's also really interesting because it's less based upon CWAS scoring. So there's a lot of different protocols for use, but actually you can use a RAS score and then just load someone. So you don't necessarily have to kind of do this ongoing labor intensive scoring. And, the inter-rater variability of the CWA or any alcohol withdrawal scoring on any frequency interval, there's a lot of debate of how accurate, and there's a lot of basically different inter-user rating differences there. Prior evidence supports that phenobarbital use, particularly for alcohol use, it's mostly in the academic emergency department and ICU settings. So there's certainly some knowledge gaps for those of us kind of in community hospitals or like our hospital. I like to call it pseudo tertiary care. So this article really kind of addresses an evidence gap here about implementation of this in a community-based hospital. The clinical question specifically is implementing a phenobarbital electronic health record order set across all care locations in a community hospital associated with improved outcomes for alcohol withdrawal syndrome. So a little bit about the method. So this is a retrospective quality improvement study. So it's a quality improvement study that involved 281 bed community hospital in Seattle, Washington. And the study itself had 254 hospitalized patients treated for alcohol withdrawal syndrome. And it looked at kind of the 11 months before and the 12 months after implementation of an EHR-based phenobarbital order set for alcohol withdrawal. So it went from April 2021 to March 2023. The study assessed cumulative phenobarbital and benzodiazepine exposure, alcohol withdrawal severity, duration of alcohol withdrawal, treatment, time from treatment initiation to hospital discharge, and then looked at safety outcomes. The protocol specifically was there's a phenobarbital EHR order set that was implemented in March of 2022. And you basically had kind of two options in terms of phenobarbital loading. You did a weight-based standard load, so 15 milligrams per kilogram, or you could do a lower risk, and that would be for patients that could have been pre-treated with another sedative like a benzodiazepine, and that was 10 mg per kg. It's really interesting. I shouldn't have cited it, but I listened to a really good podcast about this in preparation. It was from a bunch of ER doctors, and they were talking about the very interesting thing about phenobarbital is compared to benzodiazepines, there's very predictable serum concentrations of phenobarbital based upon weight, as opposed to benzodiazepines where like the same dose could produce quite a bit of variability in serum concentrations of the drug. You're also allowed to do additional as-needed phenobarbital doses for persistent withdrawal symptoms if necessary. They were available across all the ED, acute care, ICU, so you could do this anywhere that you wanted to. And they also had kind of provider education beforehand, kind of letting people know what was going on and kind of how they could access his order set. What questions do you have?
So basically, they wrote up the order set to show people how to use and order phenobarbital correctly. And then it was just available and they educated people about it being there and how to use it.
Yeah, exactly.
But they didn't like make you use it, or they didn't say the whole hospital's going on to phenobarb now.
You didn't have to, but the order set kind of defaulted to it, and you could certainly select an alternative version as well if you want to. And like that's part of what I'll get into talking about results is what percentage of people use the phenobarbital load, and vice versa. So kind of overall, like I said, phenobarbital order set implementation. The thought being phenobarbital kind of benefit of kind of both dual glutamate GABA receptor activity. Very predictable drug concentrations of phenobarbital based upon weight. The other thing I didn't mention is that the half-life of phenobarbital is really long. So anywhere from 60 to 80 hours. I've seen other ones citing 53 to 118 hours. So there's this thought you can get away with just a load and that's all you need to treat. So it's kind of nice. It's not like this ongoing maintenance for many patients. Not everyone. There are still options for additional doses, but for many people. Inclusion criteria was that you had to be hospitalized adult, so there for greater than or equal to 24 hours. You basically determined alcohol withdrawal risk based upon a couple of different things. They looked at, did a clinician order a CWA scoring set at all? Was there a positive blood or urine alcohol test within 24 hours? The other one was if you had any kind of prior alcohol-related diagnosis. So these were what they considered the risk factors for inclusion in this analysis. They also had to receive alcohol withdrawal syndrome treatment with phenobarbital or benzodiazepines. It could be either or. They excluded pregnant ladies, anyone admitted to a psychiatric service, anyone transitioning to comfort care. They did exclude, so that's a good one. Anyone with missing encounter data. And then, they also kind of took out our repeat hospitalization people. So they really only kind of counted the first admission. This is a small number of patients that often make up a large number of visits, so I think they only took one from that group.
I wonder why, because each episode of alcohol withdrawal kind of stands alone. Is it like if you got phenobarb once, you somehow can't get it again?
It was actually interesting that, the ER doctors in that podcast I was listening to, they talked a lot about the fact that it has such a long-acting half-life that actually there is concerns regarding phenobarbital toxicity with kind of repeated loads. And it's kind of, as it gets used more frequently, they talk about concerns regarding a world where possibly a patient is seen at one hospital on Monday and they get a phenobarbital load, which, as I said, has a long half-life, 4+ days. And then maybe they go to another hospital, another system on Tuesday, get another phenobarbital load, kind of stacks on top of the last one. And then they go to a third hospital. And I think this would be more like an urban setting. And so I think there's concerns regarding, if you give these repeatedly, they're going to stack up and then you're going to get phenobarbital toxicity.
Mm-hmm.
Primary outcomes were, and it's from the podcast was from much of ER docs from Swedish Medical Center. The primary outcome was phenobarbital order set, so who used it and what penetration the order set had into kind of use. They looked at cumulative phenobarbital and benzodiazepine exposure, looked at daily maximum CWA scores during the first 4 days. They looked at duration of treatment for alcohol withdrawal, and they counted that as from first to last administration of withdrawal medication. They looked at time of alcohol withdrawal treatment, initiation to hospital discharge. They had secondary outcomes looking at, did you use physical restraints? Was there intubation following treatment at some point? Was there an in-hospital mortality? They basically tried to use multivariable regression analysis to kind of adjudicate differences in pre-implementation and post-implementation patients to kind of get statistical significance here. What questions do you have so far about this? Or do you think it's a good study?
I think it's a good study. I mean, I guess I want to see the outcomes. It's so institution dependent. I guess that's my only concern. It's sort of like putting a tool out there and seeing which doctors adopt it. It's like, does it really show it's better, or is it really just showing that it's feasible?
Yeah, I think it shows two things. One, it's feasible, but also you're kind of comparing the same hospital pre and post, right? So you have an idea of how things were going before the new QI project and then after. So I think it's actually kind of nice in some regards because you have a self-control, right? It's relatively the same doctor, same nursing staff. To some extent, and especially in these cases, it's often the same patients.
Well, and it's easier to implement if you're not forcing everybody to use it. You're just putting the tool out there. So I think about our health system, trying to force all our hospitalists to do anything is probably really hard. But just saying, hey, there's a new order set you can use if you want, and we think it's better. you can just do that.
You just sub it out. Yeah. It's funny because gold standard trial, right? A gold standard research paper is an RCT, like randomized controlled trial. We've all learned that. I actually, like, as I get older and I'm in clinical practice, I actually like these QI studies a lot because I feel like it's more something like I could do that. This could be in my practice. This isn't that hard. I don't need, blinding and things like that to kind of make a change. So actually, I find these very useful in some regards.
Well, they're useful, they're simpler, and it's really just research on your own patients and your own institution, without
Yeah.
this pressure to make it fully generalizable.
Yeah. So is the trial valid? So the funding for the study was provided by the NIAA, so no industry sponsorship or bias. The authors report some additional support, one from the NIH, CDC, AHA grants. One got an honorarium from SAMHSA or ASAM, so certainly wouldn't call anything here industry funding. It's a large retrospective quality improvement study at a single site. So 254 patients is a large size, but it's not randomized. There's no placebo control. There's a plausibility it couldn't be extended to other situations. I think one thing is if you really wanted to answer the question, I would have liked a true, a soft roll in where that's you could have had a period of true head to head of a benzodiazepine versus the Phenobarb protocol, like who truly reigned supreme at this hospital. But I think the pre and post is pretty close. Not surprising, but the majority of alcohol withdrawal care is initiated in the ED in this trial. So most of the loads occurred in the ED, which I think kind of goes back to my initial kind of monologue about our hospital when we adopted it. It was really driven by the emergency department. So I still think that, any results here, it's still kind of being driven by a group that's kind of adopting it at a higher rate than the rest of us. And that's the ED, which good for them because they're probably dealing with it in the most severe forms and stabilizing first.
Well, and it's true, and it makes the whole process seem easier if basically you can get your single phenobarbital load in the ED, and then you just go up to the floor for monitoring.
Mm-hmm.
If you can often get away with a single load, like that's awesome.
Yeah. So the primary strategy here that was used was a single loading strategy. So the question is that better than a load followed by a repeat dose or a lower step down dose? Is it kind of better to do kind of like a tapering dose? There is different protocols for it. I would say that's one thing at our institutions. We have a lot of different options now. I think sometimes it's too many options for someone that might be new to the game. The authors report the relatively short period, and they kind of critique that. I actually think a year before and a year after is pretty good. I mean, 2 years is good. I don't know. This is not a long-term health outcome. It's a drug that lasts 4 days. You're doing a one-time dose. I think a year on either end is pretty good.
Yeah, that is good.
I think adoption and uptake they talk about may have been influenced with some concurrent factors. So they did have kind of an EMR change at the point in time. So this was initiated, but it was also a new EMR. And also there was a benzodiazepine drug shortage at the time. So, I'm sure that it factored it to a certain extent. But at the same token, I mean, don't let a good crisis go to waste. I think it's perfectly fine. They also talk about potential Hawthorne effect where, people got education about this. There was a new EMR order set. There was concerns that maybe that prescriber behavior would be altered based upon this. I mean, it's a community hospital. I don't think that most people, they want to just get home and do their job and take care of their patients. I don't think they typically are caring too much how they're perceived or who's watching them. So I don't know if I believe that.
Right. I feel like at our community hospital, sometimes there'd be reverse Hawthorne effect. Like you tell people to do something and they just actively ignore it on purpose.
Yeah. Rebel.
Yes. You can't make me do that.
I didn't want to say that out loud, but I could certainly see that. Like, hey guys, we got this new set. You all need to use this. And they're like, screw that. I mean, my old CWAT order set is tried and true. And we, as docs, we do a lot of heuristics where I think we tap into things we do repeatedly, right? So actually, I think it's hard to change practices. I think it's not even the Hawthorne effect. I think it's just tough to change.
Well, it is tough because you're expected to do this super quick thinking and super quick decision making. You have to see 20 plus patients a day in the hospital. You don't really have time to contemplate. You have to make most of your decisions immediately. And so once you've adopted a protocol that works and you've memorized it and you know how it works, switching that slows you down and can make your day kind of unmanageable.
Yeah. Now, so a little bit about the results. So as you said, it's 254 patients. There was 154 pre, 100 post implementation. Mean age was 53. Most were male, over 2/3. Not surprising. 73.2% were publicly insured. So they were Medicaid or Medicare, with really Medicaid being the heavier component there. Most patients have substantial prior healthcare exposure. So at least 60% of the patients had kind of previous admissions within the healthcare system. So these people were known to the system. Over half had a prior alcohol-related diagnosis, and about a quarter had prior alcohol withdrawal syndrome. Baseline alcohol withdrawal severity was similar between the groups. So kind of initial CWA was approximately 9 to 10 in both. There was no statistically significant difference. They all had very similar, statistically adjudicated comorbid conditions. So including electrolyte nutritional disorders, sepsis, inflammation. Interestingly, there's smaller proportions with liver disease, trauma, or other substance use disorders. So they thought that was slightly underrepresented. But overall, the two groups were similar. I thought it was amazing. 93% initiated alcohol withdrawal treatment within 24 hours. So, and about 2/3 of the time, 60% plus of the times, the ED staff was starting this. So, most was treated very immediately. They didn't miss the alcohol withdrawal, and it was the ER that was doing this. And 75% were managed without ICU level care in the first 24 hours. It's actually kind of surprising. 25% going to the unit. That seemed actually kind of high.
Yeah, so from your experience, that's high for alcohol withdrawal management?
I mean, I don't work in the unit, so I guess I don't really see who's going there. But yeah, that seems high, in my opinion.
Maybe they were extra cautious because of all the phenobarbital.
Maybe. So what are the results? So primary outcomes. So in terms of phenobarbital order set adoption, so 67% utilization post-implementation. So 2/3 of the time they were using this phenobarbital order set. So, and that was very statistically significant from pre-implementation, which makes sense because you're comparing to something that didn't exist. So of course it's going to be higher. In terms of medication exposure, benzodiazepine exposure decreased by 22.4 lorazepam equivalent milligrams per patient. So there was a substantially significant reduction in benzodiazepine exposure in patients after the order set. Also kind of makes sense if we're now favoring this phenobarbital order set. Phenobarbital order exposure increased to 554.7 milligrams. Also makes sense. So basically, it can show the first kind of three outcomes to show that the order set was adopted very well. We really kind of had a large reduction in benzodiazepine exposure and a higher phenobarbital exposure in our patients admitted for alcohol withdrawal. In terms of alcohol withdrawal severity, there's really no difference in CWA scores the first 24 hours. So, there was a 4.2 to 5% reduction in maximum daily CWA after that point in time. So the first 24 hours, it was the same. But after 24 hours, there was a kind of a widening of the two, with the phenobarbital group kind of showing kind of lower CWA scores. And that was statistically significant. And it was by about 5-point reduction. In terms of alcohol withdrawal severity, there was a 30.1 hour reduction that was statistically significant in the phenobarbital group. So over a day shorter alcohol withdrawal when you were treated with the phenobarbital load. I also think that this is really interesting that the time to hospital discharge was reduced by 2.2 days in the patients with the phenobarbital load. So that kind of really outperformed the benzodiazepine. And it's really interesting because I feel like that I do inpatient medicine, and this comes up quite frequently where you have someone there and they might have some minor electrolyte abnormalities, which you rapidly correct. But then they're there on day 7, still scoring high on the benzodiazepine order sets or the CWAS order set. So I think that this is really kind of an opportunity here, especially with kind of reduction in length of stay.
Well, and it's a big reduction too, 2.2 days. Usually when we see reduced length of stay, comparing two groups, it's 0.6 of a day on average.
Yeah, it's pretty amazing. In terms of what are the other results otherwise, in terms of safety, there's really no difference in prolonged physical restraint use. There was no difference in terms of intubations, and there's really no difference in terms of in-hospital mortality whatsoever. So kind of the bottom line is that the phenobarbital order set implementation really outperformed the pre-implementation benzodiazepine use for alcohol withdrawal. So there were significant reductions in benzodiazepine exposures, lower alcohol withdrawal severity, shorter alcohol withdrawal, and then kind of shorter length of stay. And there's really no statistically significant difference in any of the safety outcomes, which is what I was most concerned about. So no kind of excessive respiratory suppression, restraint use, mortality. So, it was just as safe. the question becomes like, does this help me in patient care? I actually think that this is probably the tipping point for me in care. I think there's a couple articles we talk every so often where like I'm on the fence. And I certainly have used phenobarbital order set on several occasions in terms of alcohol withdrawal. I feel like I just kind of trained with benzodiazepines, so I became very comfortable with that over the years. I do think that going forward, though, this is really kind of like the tipping point that shows that, even in a community-based hospital where it's not necessarily this kind of tertiary academic center, that you can safely treat patients with phenobarbital, that the load works very well, so not even a prolonged taper, and that actually the outcomes in terms of length of stay, kind of like reduction in severity, everything seems to be outperforming here. So I think that going forward for me, unless there's a medical contraindication, I'm probably going to be starting with a phenobarb load as kind of my alcohol withdrawal treatment of choice.
As like a subtle little prompt in St. Max's hospital, St. Max's like order set for alcohol withdrawal, is phenobarb listed as like number 1 with a little parentheses preferred choice or anything, or is it just like alphabetical what you choose?
It doesn't say preferred choice. There's multiple different. There's like they have like 6 different loads. Now that being said, can I be honest with you? I'm an attending physician. I have residents. The residents put the orders in for me, and I love them. I love them to death. So it's sort of like Free Willy the whale. Like I don't know if you released me in the wild, I don't know how
well you do
how well I'd kill anymore. But there is there's multiple options, but they certainly don't put a preference there. I did look at that beforehand. I thought about bringing that back, although to get that approved at any form of committee, they're gonna be 19 meetings.
But that would be like a good QI project if you just put like preferred or move it up to the number 1 spot, if somehow that would increase its use.
I tried to get them to add the maintenance medications, but that was shot down. We're not shot down. We didn't have the resources. Anyway, good. I think good article. That was good for me to kind of read up on, and I really appreciate it. I really liked it.
Well, it's a great article, and I hope for those of us out in the community who are still like using benzodiazepines primarily, it'll really change practice. And then I'm like thinking about outpatient alcohol withdrawal protocols as well. Can we give like outpatient phenobarb, a few tablets as a single load, and then let people do their outpatient withdrawal?
I'll have to read about that. I'm sure someone's tried it.
I know. My only experience has been a patient who got himself in trouble using too much phenobarb that he was diverting from his pet who was prescribed phenobarb.
I love with the PDMP now when it shows the little dog like next to the because he has to link the prescriptions.
Yeah, next to the vet meds. Yes, it's very adorable. Oh my gosh. Well, John, thank you. Thank you so much for that article. Yeah, I haven't had a lot of pet diversion, but I have a certain amount. Around here, our local vet seems to give tramadol to a lot of like cats. So.
And they're seizing up a storm.
Yeah. But no, that was a really great article. Hey, I did want to share a little talk back that we got about another episode from our addiction medicine podcasting colleague, Dr. Casey Grover. He makes a podcast called Addiction Medicine Made Easy. And if you're listening, Dr. Grover, we had another listener actually wrote in just to thank us for introducing him to your podcast. So everyone should definitely subscribe to Addiction Medicine Made Easy as well. So Dr. Casey said, hi, friends. I just listened to your podcast on treating alcohol use disorder in patients with severe liver disease. And I wanted to share what we are doing in our practice here in California. And this is now no longer a quote, but John and I had presented an article previously where they had given 2 or even 3 medications for alcohol use disorder and severe liver disease. And I think it was episode 78. And both of us had admitted that we usually just gave 1 medication. And if it didn't work, we switched to another one. And this article had given multiple medications, and we were saying that would change our practice. So Dr. Casey wants to share what he does. He said, my experience has been that very few patients respond well to monotherapy in treating alcohol use disorder. For example, some people have very little response to oral naltrexone, and as such, my standard of practice is to start 2 medicines for alcohol use disorder that work in complementary ways. For instance, I might start gabapentin and naltrexone for someone with underlying anxiety. So, I think he's got an idea there, and I had emailed him and said, well, how do you choose which ones? And he said basically he chooses naltrexone and then adds on a second medication based on, other comorbidities. So do they have depression? Do they have headaches? Do they have anxiety? And that helps him choose the second medication. So I'm really thinking this is more reinforcement for me to choose multiple medications for alcohol use disorder. I did, though, I was lecturing to the new interns on addiction medicine just on Tuesday of this week, and I told them they could use multiple medications, but I did try to kind of look it up. I did a quick survey of resources for PCPs on how to treat alcohol use disorder, like Up to Date and the Annals of Internal Medicine series, and none of them said anything about dual therapy. They all said monotherapy only, specifically that evidence is lacking for any other option. So if you're an alcohol use disorder treatment researcher, I think this is an area that is really ready for some attention. John, have you gotten a chance to use dual medications for alcohol use disorder since we talked?
I do have a couple of people in it. It works. Like I said, it works okay. I think the medications, they've been helpful. I feel like they're more harm reduction. I haven't had these kind of like, with a few exceptions, I think I just don't have these robust responses. It's more like that people improve. But I think that I don't think I'm probably treating hard enough, to be honest with you, either.
Right. 3 medicines. You got to go up to 3.
I need to go 3. You got to get deep in the paint.
Yeah. All right. Well, if you get to 3, let us know how it goes. And thank you, Dr. Grover, for sending us that information. And that's all we got. So I want to thank everyone for listening to the Addiction Medicine Journal Club. As you know, the best part of any journal club is a conversation, and we want to hear what you have to say. John and I don't just want to hear our own voices. We really want to learn from our colleagues, and that's why we have Journal Club. So to have your opinions about the articles or any feedback at all included in a future episode, please send us your comments. You can send us on social media, email, join our Facebook group. The links are in the show notes. Original theme music was composed and performed by Benjamin Kennedy. Audio editing by Michael Bonanno, CME support from MyCares, and produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. So thank you for being part of the conversation. Have a great day.